Welcome, everyone, to the second webinar in our series, Building Resilient Systems Towards Cervical Cancer Elimination. My name is Heather Brandt, and I direct the HPV Cancer Prevention Program at St. Jude Children's Research Hospital. For this webinar series and the Access North America initiative, I'm delighted to be co-chairing with Julie Terode, a board member of the Institute of Cancer Policy, Director of Strategic Partnerships, Community and Patient Engagement, visiting researcher at King's College London, and the IGCS Access Initiative facilitator. Our first webinar in this series was held just in mid-June and brought together global and regional health leaders to assess progress towards cervical cancer elimination by 2030, covering HPV vaccination trends, the transition to HPV-based screening, including self-collection, and treatment advances across the United States and Canada. Key themes of that first webinar included the importance of acting across all three pillars simultaneously, addressing equity gaps for underserved and Indigenous populations, and country-level progress updates demonstrating that elimination is achievable, with Australia on track by 2028 to 2035, Canada projecting elimination by 2040, and the US modeling showing elimination could be expedited by at least a decade with stronger screening and treatment efforts. And one of the memorable lines was from Tamika Felder of Survivor, our advocate and ambassador, who shared, "Every cervix matters." So while we didn't have time for a moderated discussion with presenters, we were able to circle back and ask Dr. Kathleen Schmeller of MD Anderson Cancer Center, who was one of the presenters regarding the treatment pillar, a follow-up question. So the question was, if we fast forward 10 years to just before the 2040 benchmark, when Canada and the US should be nearing the elimination threshold, what one treatment system change will have made the greatest difference in achieving elimination? And Dr. Schmeller said, and I quote, "The single most important treatment system change will be ensuring that more women with abnormal screening results return for timely follow-up and receive high-quality diagnosis and treatment of pre-invasive disease. Closing this follow-up gap will prevent progression to invasive cervical cancer and be one of the most powerful drivers of elimination." So if you missed the first webinar, you can get the recording and a PDF summary on the IGCS website. And on that note and that powerful statement and recommendation from Dr. Schmeller, I'll turn things over to my colleague, Julie Terode. Julie?
Thank you so much, Heather, for that wonderful recap of webinar one. And welcome everyone to our second webinar in the summer series for IGCS. Today, we're going to be focusing on screening and all critical linkage to care that encompasses pillar 2 of the ambition to eliminate cervical cancer globally. If we just go to the next slide, a couple of housekeeping points. We welcome your information on the chat. Introduce yourself, tell us what organization you are joining from, and we are encouraging you to submit your questions to us in the Q&A feature. If we can't get to all of those questions, we will respond separately after the event. But, please use the chat also to share any helpful links or materials you might have to share on this important topic. So moving on, we have an excellent panel of presenters today. They're going to be challenging us on adoption of the gold standard of high-performance HPV testing and sharing learnings from their respective experiences to date as researchers and implementers in their own communities. I'm happy to introduce Professor Marion Saville, an anatomic pathologist and executive director at the Australian Centre for Prevention of Cervical Cancer, Dr. Gina Ogilvie, research chair at the Global Control of HPV-related Disease and Prevention and senior public health scientist at the British Columbia Centre for Disease Control, and Jane Monte Allegro, Associate Professor at the Department of Behavior Science, the University of Texas MD Anderson Cancer Center, and Isabel Scarinci, have I got that right, Isabel? Sorry about that. Behavior Scientist and Senior Advisor for Global Cancer at the University of Alabama at Birmingham, Hersink School of Medicine, and the O'Neill Cancer Center. So thank you all for joining us today. Marion, I invite you to please share your screen and kick us off with an overview of the levers for impact in terms of Pillar 2 and sharing your insights from your work in Australia. Over to you.
Thanks very much, Julie, and thank you very much for the invitation to present today from Australia, where it is a very cold winter morning here in Australia, in Melbourne. Today, I'm just going to briefly touch on a global snapshot, talk about what we see as the key levers for implementation and impact, and particularly within the Australian context, and then the global implications of that experience. So, of course, I don't need to tell people about the 90, 70, 90 targets in this audience. I'm sure you're well aware. But with only 5 years to go, progress has been uneven. And we really, while we've had strong policy adoption, there are significant gaps in implementation around the world. And screening, it remains a critical bottleneck, and after treatment will be the next pillar to really impact cervical cancer incidence. Of course, vaccination is so critically important, but will take a longer time to impact incidence. And what we need to do is translate global strategy into effective population-level delivery systems, and that remains a key challenge. So while the global strategy is clear, the question is how we accelerate the global approach in real-world systems. So from our perspective in Australia, looking at our own program and our work in our region, we would say that obviously the most important levers for impact in relation to screening are that transition from cytology to HPV-based screening. And my background is as a cytopathologist. So I spent a lot of my early career in optimizing cervical screening in our laboratory and in Australia. But I have recognised early, and I think it's still challenging, that many of my colleagues globally and even still in Australia are resistant to this change, and that's a challenge. We need to scale self-collection to expand access and choice of screening for a whole range of reasons. I'll say more about that. And in some cases, we need to move service models closer to communities with mobile delivery and outreach models. We've heard about the essential linkage to care pathways and ensuring follow-up and treatment, because without that, screening is an activity, but it won't have impact on outcomes. And all of this needs to be underpinned by strong data monitoring and accountability systems so that we can track progress and equity, and I'll say more about that as well. So just some background from Australia. Our organised program began in 1991. It was a 2-year PAP program from ages 20 to 69. We had structured screening program, and it was achieving reasonable coverage and high follow-up rates supported by screening registries, that really critical underpinning data system that had a really important role in driving follow-up and also telling our governments how our program was working. We had strong laboratory accreditation requirements supporting high quality cytology, and we probably reached the limits of what could be achieved with high quality cytology in the early 2000s, with cytology as the primary screening test. So you'll see that following the organisation of screening, we had this decline in cervical cancer incidence, and then this plateau that is to do with the limits of high quality PAP screening. Then in late 2017, our program changed. It was years of policy advocacy and work with the federal government, underpinned by modelling that predicted that if we switched from PAP smears to 5-yearly HPV tests, we could achieve reductions in incidence and mortality compared to what we had at the time, what I say there was current, so the 2-year PAT program, of at least 20 and up to 30% reductions. So that switch was to 5-yearly HPV screening, women aged 25 to 74, partial genotyping, and direct referral to colposcopy for anyone with HPV. That was challenging, as I said, because of the success of the PAT program, people saying if it isn't broken, why would you fix it? Pushback from stakeholders, especially in relation to the longer interval, the longer screening interval, and the increased age of starting screening, both of which had those choices had the safety challenged, and it was quite a complex communication challenge with the community, that this was not disinvestment, but this was a better balance of benefits and harms. The strength of the change came from the strong underpinning framework from the previous program, so the organisation, the registries, and support at all levels of government based not only on the strength of evidence, but also because unusually this change was not only going to give us better health outcomes, but at a lower cost. And that lower cost is principally driven by the increase in the interval. And then self-collection came along, and the landmark meta-analysis by Mark Arbon in 2018, essentially demonstrating that self-collection is as accurate for the detection of cervical cancer precursor as clinically collected samples, as long, of course, as you're using a nucleic acid amplification technique such as PCR. So that's important because some tests are not as accurate with self-collection, but most of the commonly used tests these days are. We have found in our laboratory we've been able to demonstrate stability out to 28 days and up to 50 degrees centigrade, we're as close as we can get to 100% humidity, and that's been important for us in servicing our remote Aboriginal communities, for example, because those swabs are sent to us through the mail. And particularly during the pandemic, we did have problems with getting them within the original 14 days. So we extended that stability study and the claim now out to 28 days. And of course, this means that we have the possibility of flexible delivery of screening services. Yes, we've got point of care, but with that stability, we can send the swabs to laboratories and be confident that the results are going to be accurate. As you will all know, self-collection overcomes many cultural barriers. And because you don't need a healthcare practitioner to take the screening sample, this facilitates scale up by preserving our trained workforce, our nurses and doctors, to examine women who have HPV and in some contexts provide same-day treatment. So this leads to improved equity, not only between countries, but within countries. And so it took us until July 2022, after the landmark meta-analysis, to make all the changes in relation to our policies and procedures in Australia. So prior to July 2022, self-collection was available, and the criteria we had was aimed at balancing what we thought might be a loss of accuracy against trying to expand the reach of the program. And that was based on an incorrect concern about accuracy. And once that was clear, we were able to offer self-collection in the Australian program to all screening participants, so they should have a choice as to how their sample is collected. This is a breakthrough in the reach and equity of our program in Australia. It's never been possible while practitioner-collected samples were needed. And we do see we've had disproportionate uptake of self-collection by unscreened and underscreened people. At the time, very few HPV assays had self-collection on label, and we had to undertake extensive in-house validation at our laboratory, and as the reference laboratory in Australia, assist other labs around the country to achieve that. Self-collection is now widely available, and we just ticked over at the end of last year, half of all screening samples are taken by women themselves, so just over 50% are self-collected. In November 2023, after a piece of work that Julie was involved with as well in Australia, we launched our national strategy for the elimination of cervical cancer. And we realised early on how important equity would be in that strategy. As you've heard already, we expect to eliminate cervical cancer and reach that 4 per 100,000 target by 2035 in Australia. And of course, this is a disease of inequity. So equity is woven through our national strategy. You can see that we identified 5 priority populations. And this was really important, was to consult with these priority populations during the process. It's not all rainbows and unicorns in Australia. Yes, our latest incidence is 6.2 per 100,000 when measured against or standardised against the world population. But you'll see that our Indigenous population is twice as likely to develop cervical cancer as other Australians, and actually almost 4 times as likely to die of it. We also see this socioeconomic gradient with cervical cancer less likely in our most affluent communities and also in major cities as compared to more remote populations. So equity is definitely an ongoing problem. And in order to address that, the way we set up our advisory groups is that we definitely had our technical experts in our panel, pillar advisory groups, but we had an overarching equity advisory group. And they were involved in each of the meetings and included in the technical meetings. And indeed, at the highest level, our expert advisory group for elimination response, chaired by Professor Karen Canfield, who I understand you heard from at the first of these events, was made up of technical experts. But circled in yellow here, you see the CEOs of the peak bodies for the priority populations we were talking to. So at the table from the beginning of the consultation, the design process, and represented at the highest level. And I think that was really important for the strategy we came up with, which you can find quite readily online, and just leaving you with the vision. So we're preventable cervical cancer is a disease of the past in which Australia's diverse communities have equitable access to information and culturally safe and inclusive vaccination, screening and treatment services. So from our perspective, the strategy was supported by this coordinated governance. It really emphasised the importance that we had already adopted the HPV-based screening, and we talked about very much the integration of self-collection into the program and the opportunity that afforded to us for us to reach our underscreened population. We've had ongoing program adjustments as this is unfolded, and investments into many of the recommendations from the strategy, and we focus on monitoring, reporting coverage, and also equity to the extent that the data allows us to. So one of the recommendations that we have some data gaps we need to close in relation to some priority populations, but we are working on that. I just wanted to talk a little bit now about what I mean by underpinning data systems. So Australia, like many countries around the world that have been successful on the old-fashioned PAP program, has been underpinned by cancer screening registries. And this includes our counterparts in New Zealand, in the UK, the Nordic countries. And these platforms collect information about all screening activity, and they're meant to give a picture of a participant's journey through the screening pathway, regardless of where they get their healthcare from. And on that basis, they need to be supported by enabling legislation that allows the collection, appropriate storage and use of this information. And it is highly protected, and there's a lot of community confidence and these days, a lot of security around that information. It supports the active follow-up of all participants. So the registry is looking for a signal from colposcopy or biopsies, for example, that people referred have had that. And if not, a cascade of communications go through the original clinician, the clinician to who the patient has been referred, and ultimately to the participants to remind them and bring them in to colposcopy. And we do achieve follow-up rates of over 80%. Within 12 months of using those techniques. But importantly, we also monitor and evaluate the performance of the screening program at quite a granular level, and that gives reports as to how we're travelling. This is where we get the information about coverage, uptake of self-collection, and completion of the pathway. So just getting to the end, a final slide to put in a plug for our partners in Malaysia and show you how actually the CanScreen registry has been used from Australia, has been used by the ROSE team. So you'll be familiar with the fantastic work led by my colleague and friend, Prof. Wu, across their pillars, including the importance of education and advocacy with their communities. And we provided from ACPC technical support from a laboratory and registry context, and now the Rose Foundation, they're up and running on their own. They know their communities, and they do all of this work, and they're developing their own technical expertise. So they're relying on us less and less, and the scaffolding's coming down, and they are really, we're really proud of where they're at. But we adapted CanScreen to be used within a very, very different context in a middle-income country. And it's been very successful. And I shout out to them. They use event-based screening. They come back to a low-cost test in a laboratory. And through the use of the registry, actively through their care team uses the registry to understand who is where, they are achieving 88% follow-up, which is better than we achieve in Australia. And they're doing an amazing job. So what does all this mean globally? Policy commitments got to be matched by delivery innovation, and that's got to be accompanied by financing. Equity-focused models are essential to closing the screening gaps, and community-centred approaches are critical to reaching never and underscreened groups. We've got to listen to them. And even in Australia, we have point-of-care testing now being delivered to remote Aboriginal communities. And that has been a really exciting innovation funded by the federal government. And of course, success depends on aligning screening, follow-up and treatment. So, I think Kathleen Schmela said it well. We've heard, and I'm sure that will be more of a focus today. It's challenging sometimes to get people in the front door of screening to do that first screening test, but it's absolutely important that we don't stop there, that we make sure that we get as many women as possible who are screen positive into follow-up and treatment pathways. So thank you very much, and I'll stop there.
Thanks so much, Marion. And I don't mind at all giving Project Rose a little plug, and I recommend everyone have a look at their self-collection program. You summarized your slides very well. Thanks very much for emphasizing data-driven program shaping and also the equity element. And I enjoyed working with your eager group as we designed the strategy. So let's move on quickly now to Professor Gina Ogilvie to hear from her work in British Columbia. Over to you, Gina.
Thank you very much, and thanks for this invitation. Can I just get a thumbs up that you're seeing the correct slides, please? Yes? We're good? Great, thank you. So I'm delighted to follow Marion and just underpin one of the things we wanted to do today is just underpin the robust evidence there is to move from PAP screening to HPV. So I'm just going to give sort of a highlight of some of the key evidence that we used in Canada to help us guide as we moved in our provincial jurisdictions towards HPV-based cervix screening. So we've seen this slide already, and today I'm just going to highlight for you in terms of Canada, our goal is a little bit higher than the WHO goal. We're going to move to, we are aiming for 90% of all individuals who are eligible for screening have an HPV test. So just a background about Canada, we're a publicly funded health system where screening is covered. And every year about, once a day in Canada, a woman dies from an entirely preventable cancer. Most of the cancers occur between the ages of 30 and 59, and it's the third most common cancer for women 35 to 44. So really shouldering a substantial burden for women in midlife. And similar to what Marion talked about, we have a large burden of our cervix cancer cases in women who've never been screened or are overdue for screening, with particularly visible minorities, Indigenous women, and women from rural areas overrepresented in our invasive cervical cancer numbers. So I'll talk a bit about British Columbia, where I live, which is the most western province of Canada. In 2024, we transitioned from Pap screening to HPV primary screening anchored in self-collection. But really our principle was that if this, one of the ways, and I think Marion's group has done this as well in Australia, one of the things I really want to stress is really meeting women where they're at. So women can self-collect, they can bring a kit in, we can get the kit mailed to them, they can pick up a kit at their practitioner's office, they can bring their own mail kit in and have their practitioner take it, they can talk to their practitioner about it and self-collect in the practitioner's office. And we really did work to make sure that women, however women feel most comfortable screening, they can get their screening. And I'll just talk a little bit of some of the evidence that underpinned this approach and of course underpinned Marion's and all of the work around the world in European countries moving to self-collection and HPV-based screening. So I think it's helpful for people to realize that a lot of this work has been going on for many years. My first publication on self-collection was in 2007. So we're heading up to almost 20 years that people have been looking at this. So I think sometimes it's framed as this novel new thing. And I think it's important to know that folks have been working on this transition for a long time. So what are some of the key underpinning evidence? First of all, is the most important thing is for a screening test is that HPV testing detects cervical precancer earlier and more accurately than cytology. So we have one-time sensitivity for HPV test at about 96% compared to cytology at 53%. We've accommodated cytology's poor sensitivity by repeating it frequently. So that's why we've repeated cytology in this way. It's not because cervix cancer is a particularly fast-growing cancer. It is because we accommodated the relative limitations of cytology. There's a reduction in specificity, and we can talk a little bit about how we've worked to increase specificity with things like genotyping, reflex cytology. So that's the first thing. We've got a very good test that has a higher sensitivity, which we know is what we anchor screening programs in. The second, and Marion alluded to this, is the very good agreement between a patient and a provider collected specimen. This again is because we were looking for HPV DNA in the vaginal secretions. We don't have to see the cervix to get a good sample. So this is a foundational review. So I'll talk a little bit about the HPV focal trial, which is a large primary care screening trial where we looked at actually not cross-sectionally, but actually prospectively if you offered women HPV or if you offered them a PAP, and what were the outcomes for cervix screening 4 years and beyond. So again, just to anchor so folks don't feel this is something super new, we've got, now heading up to well over 20 publications on focal trial and the data. So there's lots of robust data, and that's just one of the 3 and soon to be 4 additional trials around the world that are looking at HPV versus cytology. So HPV at its core was a randomized trial where we looked at HPV conducted every 4 years versus cytology conducted every 2 years. Our primary endpoint was CIN3 detected at 48 months. And we looked at another number of other important outcomes, including rates of colposcopy and cost effectiveness. So I won't go into detail in this, but just know that the big outcome was that we did HPV in the intervention arm, and we followed them up for those who were negative, we followed them at 48 months. And at the end of the trial, we did both HPV and cytology to do a complete census of events. In the control arm where we offered cytology, we did cytology. Then we did cytology at 2 years for those who were negative. And then again, a complete census at the end. There's the pathways, which for those interested, we could connect online after, but just know that it reflected what is usual practice. So what were the key findings? First of all, when you offer HPV testing, 48 months later, those who had HPV offered to them had significantly reduced precancerous lesions, CIN2 and 3. So HPV detected those relevant precancerous lesions earlier, and then 48 months later, those folks who received HPV had significantly lower rates of both CIN2 and 3. Equally, if not more important for a screening test, when you have a negative HPV, it offers you tremendous reassurance compared to that of a negative cytology. So the risk ratios for precancerous lesions in women who are HPV negative was 0.25. That's a risk ratio compared to those who had a negative cytology. So really a tremendously reassuring test. If you're HPV negative, your likelihood of having precancer 5 years later, 4 years later in this case, is substantially lower. And again, this makes sense if you think of the pathology. The only reason we had frequent testing for cytology was because of the limitations of the actual test, not the disease itself. And here's the cumulative incidence curve that also shows this. So we've been fortunate with Focal to continue to follow up. So this is looking at negative HPVs at 10 years. And again, a negative HPV at 8 to 10 years out, you can see that it's almost a third lower if you have a negative HPV compared to a single negative cytology screen. Again, offering us both confidence in the results of HPV testing and that we can extend out the screening interval compared to cytology. We also were able, because we did both cytology and HPV at the end of the trial, to compare which approach missed more cases, because we had an HPV arm that then we had double testing at the end, HPV and cytology, and we had a cytology arm where we had double testing at the end. And what did we find? Was we found that substantially more CIN2 cases were missed by that cytology than were missed by the HPV test. So 25 cases of CIN2 were missed by cytology that were then detected by HPV at the end, compared to 3 that were detected that were missed by HPV but detected by cytology. Really offering that, again, reassurance of an HPV test. One of the things, though, systems do need to plan for is, particularly because, and it makes sense, when you have a better test, you're now going to, when you initially introduce it to a population, you are going to initially detect more cases as you do with HPV. So that does put a burden on colposcopy that can be managed by system planning and how you roll it out. Perhaps you start by rolling out HPV for 50 plus to make sure those women who are closer to exiting screening have a high performance test, if your system is worried about the burden on colposcopy. But what we learned about colposcopy is that burden does not stay. After the first round of HPV testing, you can see here in British Columbia, you get a dramatic reduction in the colpo rates. And as you can see, at 9 and 10, 11, 12, 13 and 14 years, there's significantly lower colpo in those who had HPV 10 years prior than those who had cytology. So while there is an initial burst of colposcopy, you then ultimately get a substantial reduction. So that need does not continue forever. And we also know HPV is highly acceptable by women. We also, in British Columbia, spent time focusing on those key groups that we want to improve participation rate. This includes women who are impoverished, women who are new to Canada, Indigenous programs, gender diverse folks, and across the board, we found that it was a highly acceptable approach, particularly to those key communities who we want to improve access in. So where we are at in British Columbia is we offer HPV self-collection or clinician collection for those who choose, to anyone who 25 to 69 who has a cervix, including women and two-spirit, transgender, and gender diverse folks. You can mail the kit to yourself, or you can get it done at your clinician's office, and you can and we have a whole pathway for the follow-up care. We use the Copan flock swab, and we are testing it on the Roche Cobas right now. And you can see here, when we introduced it, there's been a significant uptake. So first of all, we have higher rates of screening and significant interest and uptake in self-collection. So what are the next steps? Really, I think we have opportunities to exit screening earlier, potentially, particularly for those women who, and Marian alluded a little bit to this, that we have such scarce practitioner resources. One of the beauties, and this isn't why we're doing it, but self-collection does allow, means that practitioners don't have to do PAP screening. So that also opens up their schedules for other things. But also for women who've been well screened and who have low risk, is there a chance now with HPV, because we've screened them so many times with HPV, could they exit screening earlier? Also the opportunity with vaccination, we anticipate also needing to screen less. So really exciting opportunities. So I want to thank everyone for the time today.
Thanks so much, Gina. Really great to see the emphasis on data equity as well, but also that working with the colposcopy community to really look at how those volumes are managed a new way of care. Marion, we've had a question come up in the chat specifically on introduction of self-sampling in Australia. Could you maybe just talk to us about the stepwise approach that you had? People asking about how you would recommend doing that.
Well, first of all, I would say that every community is different, and even HPV, the switch from PAP to HPV, we did on one day across the whole country after a very strenuous debate about whether we could do it more gradually, and we came up against advice around communication with the community and the difficulty of offering different screening to different people at a point in time that would be challenging. And similarly with self-collection, just because of the way our system works, it was July 1st, 2022. We had to adjust our guidelines and a number of our regulations in relation to pathology to make that possible. So we introduced self-collection on that day, and definitely we saw detractors, particularly from clinicians who I think basically felt that they couldn't believe that it was going to be as accurate. And even clinicians not understanding that it works and it's easy for women to do because we're not trying to reach the cervix with the swab. I mean, some in surveys said, I don't think that women can get that swab into their cervix, and I don't think they can either, but they don't need to. So I hope I've answered the question.
Yeah, thanks very much, Marion. And that's definitely something that's come up around the difference between a vaginal swab and a cervical swab. And I think we need to get that message out to women. And as soon as they, try the test, the sample, look at that brush. I've seen people realize, oh, it's not like the pap smear. It's not going to hurt me. I can do it. So we just need to encourage people. Any tips on your side, Gina, before we move on to Jane?
Yeah, totally agree around I've actually had women so relieved when they understand that they can collect it themselves. And again, other women who say, no, I'd actually prefer you as the clinician to do it. And I think that it's really, when we talk about access, you need to listen to what women want and really meet them where they're at. So yeah, I think Marion's exactly right. Yeah, we don't need you to meet the cervix. So something you just don't have to worry about at all.
Thanks very much for that, Gina. So let's move on now to Texas, and we're going to hear from Jane Montealegre about reaching underserved communities. Over to you, Jane.
Hello, thanks so much for having me. I'm very pleased to share the work that we've been doing in Texas, and let me just make sure I'm sharing my full slide. Are we in presentation mode? Yes. Okay. So
we are. That's good.
Okay, perfect. So I'm going to talk about working in and with communities for equitable access to services, and given some updates on the work that we're doing in Texas, and wonderful to see all the representation from Texas in the audience. So in the United States, we have a very different system from the one that was described for Australia and Canada, whereby there's many differences just by state and even within counties in terms of different payer mixes, different not having universal healthcare access, but rather having multiple different modes of having healthcare coverage, which very much affects how we are going about doing our cervical cancer screening programs, in plural, in the United States and of course in Texas. But just to move us into the United States, in the United States, we continue to have about 13,000 cervical cancer cases each year with about 4,000 deaths. And we have these major geographic disparities in terms of the burden of disease. Nationally, we've seen that we've stabilized, like has been previously described for Canada and Australia, with this stabilizing incidence and mortality. We call it stagnation. Again, I think really reflecting, like Gina said, sort of reaching the limits of what we can achieve with cytology-based screening. And so we've seen this over the past 20 years. We haven't been able to move the needle all that much. And I think what's really alarming for us is that not only do we have that stagnation, but we've actually been able to demonstrate, and this is the work with my colleague, Dr. Tricia Ambery from MUSC, showing that for some subpopulations, we're actually seeing an uptick in cervical cancer incidence and mortality. So it's not just an artifact of increased screening, it is in fact leading to more disease burden, particularly in low income counties, and then in rural counties as well. And again, this is work by Dr. Ambery, who was really able to show that this increased incidence and mortality is really arising in the counties where there has been this persistently lower rates of screening. Really demonstrating, I think, that we can in fact say that the declining cervical cancer screening rates that we've seen over the past 20 years are in fact problematic in terms of really sort of putting major limits on the disease and on the decreases in disease burden that we were previously able to achieve after widespread implementation of screening. In fact, like I mentioned, over the past 20 years, we have seen a very significant decline in the percent of individuals nationally who participate in up-to-date screening. And this is not at all by any means equal across the population. We see disproportionately higher rates of screening under attendance or underutilization amongst those who are uninsured. So these are people who do not have any healthcare coverage in the United States, a sizable proportion of our population, in absence of a national or state program. We have those who are publicly insured with insurance, again, either with the national publicly insured programs that are available or at the state level. Disproportionately under representation of people of color in those who are screened, and of course those who are living in rural areas. So when we're talking about our cervical cancer plan in Texas, it is very much equity driven and equity based. We are proudly working on an elimination plan, very much following in the footsteps of the amazing work that's been done in Alabama that my colleague Isabel Scrinci will talk about next, as well as the amazing work of Heather Brandt in the Southeast and Louisiana and Florida and Oregon and all the states that have been before us. And so we're excited to also be launching our plan in the next several months. Our plan is very much, again, sort of in the absence of sort of a government entity that can take this on. We are really a group of volunteers organized through a coalition in the Cancer Alliance of Texas, which is out of our State Department of Health and Human Services, that puts together this alliance, and we've come together as a coalition of organizations really invested in eliminating cervical cancer in Texas. And of course, we are very fortunate in Texas to have state funding for cancer prevention through the Cancer Prevention and Research Institute of Texas, as well as 4 NCI designated cancer centers, a robust state university system, and also a Texas Cancer Plan authored by CPRIT that already really embraced elimination of Texas. And so we're really able to jump in and think about what does this look like in terms of implementation. And so our plan, as all, of course, follows on the three pillars. And today I'll talk about what we're doing in screening and management. So the big question is, how are we going to increase equitable access to screening? I've already demonstrated through the data that our problems in terms of cervical cancer incidence and mortality really can be pinpointed down to inequitable access to screening. And so what we see in Texas is we have about 75% of the state counties are actually those that are medically underserved areas or healthcare uh, um, areas lacking in healthcare. And this looks very diverse across the state. Medically underserved areas are both rural areas, like we see up here, with where we have low population and not having sort of the transportation and whatnot and local availability of services. But then we also see medically underserved areas. For example, this one within a mile of the largest medical center in the world, also being an area where access to healthcare services is quite dismal. And so we have diverse reasons why we have inequity in terms of access. And this really is reflected in kind of how we're thinking about our plan and our pillar two. Specifically in Texas, we really started thinking about what are those opportunities to increase screening coverage for the populations that carry the disproportionate burden of disease. And through the work that we've done in our group and with my collaborators, we really pinpointed to an important and I would say imperative role of what we call safety net health systems. What are safety net health systems? In the absence of having a national program where healthcare is available to everybody, we have a system really where you have privately insured patients who are seen in facilities through this private insurance. But then we also have a safety net whereby we try to catch those who do not have the same access to healthcare. And this is in the form of county safety net health systems, community health centers, rural health clinics, charitable clinics, health department clinics, and myriad others. And this really forms the safety net. And they provide services, again, disproportionately to the populations disproportionately burdened by cervical cancer. Rural, racial, ethnic, minoritized populations, low socioeconomic status, and those who are uninsured. And I think it's really important to note that community health centers see upwards of 30 million patients a year across over 1,500 individual organizations that are, again, independent and individual. And this really does comprise a large proportion of these populations. For example, 59% of safety net patients are publicly uninsured, 90% are low income, 65% are people of color, and 18% are uninsured. And so really these do offer an opportunity to reach the populations that are carrying the disproportionate burden of disease. And we know through, again, the work that we've done that we can mitigate population level disparities if we increase screening rates in community health centers. In a recent analysis, we showed that the proportion of individuals receiving care in safety net health centers is extremely much lower versus what we consider to be sort of the national average, which hovers around 80%. In fact, we see only 55% coverage of screening in these community health centers. And we were able to demonstrate, and this is again work by Dr. Ambery, showing that if we were to scale up screening to 90%, which is what in the models shows us like Dr. Brandt mentioned, reducing the time to elimination by over a decade. If we were to reach those 90% screening goals in our safety net health centers, we could in fact mitigate or eliminate a lot of the disparities that we see in terms of underscreening. Again, through biracial, ethnic, and minority status, uninsured, publicly insured, low socioeconomic status, and rural status. And so we in Texas really think that this is something that really needs to move from potential to priority, and that we really need to accelerate implementation and this scale up of screening in our safety nets, specifically through self-collection, which just recently became available to us in the United States. This was approved in 2024 for use in clinics, in a clinic setting, in a healthcare setting. And then just a couple of months ago, we got our regulatory approval to use this in an unsupervised or home-based setting. And so this will be part of the mix as we go forward. But really, we've been working a lot on how do we partner with safety net health systems and other organizations that serve safety net systems to co-create programs around scaling up their screening through offering self-collection as one of the options for screening. And so we use the INSPIRE methodology, as Dr. Brandt talked about in the previous one, but really working together through participatory action research to co-create programs, and really, again, driven by the community in terms of what this looks like. And so, and again, we are fortunate in Texas to be able to have funding at the state level for this type of program through CPRIT. Thus far, this has looked like partnerships that we've had with community health centers, in which we partner with the community health center to integrate self-collection into the primary care workflows as an option, particularly for underscreened, but there is no mandate to switch over. In fact, I think only about 2% of the US population is screened just by primary HPV testing by itself. So this is really us thinking self-collection will drive the demand once this is offered as a new opportunity. And so we're offering this as an option along with other screening forms that are also used in the clinic, and everybody really has that description. And based on, really following what Dr. Schmaler advocated for in the previous webinar, we've done a lot of work in terms of strengthening referral networks for colposcopy and building capacity for management through colposcopy in those systems. And of course, providing culturally concordant patient navigation, which is crucial for a population that has such high levels of underservice and uninsured rates. And so just quickly, this has been mostly in the form of collaborations with individual clinics, but we are doing a lot of work to scale this up through higher level aggregation and forming peer-to-peer learning networks. My colleague Susan Parker is starting an ECHO network where we will work with community health centers to implement self-collection. And then we've also been working with our state primary care association, the Texas Association of Community Health Centers, again, to provide this facilitation and peer-to-peer learning so we can really roll this out to others. And then beyond Texas, really doing the same for federally qualified health centers and other community health centers at a broader level by, again, providing implementation support and building connections for peer-to-peer learning. And with that, I thank you, and I will stop sharing.
Thank you so much, Jane. That was a really interesting approach to use that multiple safety nets approach to reach women with likely to have higher risk of cervical cancer. And we look forward to hearing more as your program gets implemented. Now, I see there are a few questions, but I'd really love to give maximum time to Isabel. So over to you, Isabel, for sharing what's happening with Operation Wipeout in Alabama. Over to you.
Can you hear me? Yes.
Yes, we can, and we can see your slides also. Go ahead.
Good. So it's always hard to do the last one, so I'm going to try to rush. but I'll be happy to answer questions via email. So thanks for the opportunity to share what we are doing in Alabama that's called Operation Wipeout. How do I advance now? It's not advancing. Let's see. Okay, so Jennifer Pierce-Young talked last time, but if you're not there, so she talked briefly about Operation Wipeout. It's a statewide effort to eliminate cervical cancer as a public health in Alabama based on the 3 pillars that was already discussed in this webinar. What is very bottom-up approach where we brought healthcare providers, leaders from all over the state, especially rural counties, and ask them, what should we do? And they help to put and write this statewide plan. And we are very lucky and that we do have a state health officer that's very supportive and was able to officially launch this plan for Alabama because we thought that was very important to have government support on this, because at the end of the day, cervical cancer, being a disease of poverty, is going to fall on the public health system, the breast and cervical cancer early detection program. And it's the same for the work we are doing through Rotary in low and middle income countries, where we encourage them to really partner with government for sustainability. So we really got everybody together, people that were already doing things, for us to work in a unified mission. And we're proud to say we were the first, and now others are following, which is amazing. So we have very important core principles. It's a shared ownership. With the feedback that we got is that it shouldn't be led by one organization. It should belong to everybody. So if you go to our website, none of our materials are copyrighted. We really want this to belong to everybody. And also the importance of evidence-based. So everything that's there, it's evidence-based, because credibility was very important and have a unified purpose. So this, and also one of the things that before we launched the plan that was very important and was already talked about, is that we need to make sure that we could take care of the problems we find. We couldn't create expectations and not follow through. So we got the commitment from the cancer centers across the state to treat the cancers we find. We got the support for everybody. For us, what's very critical is really the community engagement and the partnership, with civic organizations. We do not, this is pretty much unfunded effort. Is action without fundraising. So the partners can use Wipeout and raise their funds for their activities. There's no exchange of money, and it's one message. And this is our goals that are consistent with some of others. And so that's when we realize with the plan, it's true that we do have the tools. And a lot of times, us in the medical community, we talk to each other and we think that everybody understands. And involving Rotary clubs, Rotary is our secret weapon here. Rotary has been our major partner, because Rotary understands eliminating a disease, because through Rotary, polio has been eliminated. So that was really for us very important. And we realized that's no longer in our hands. We have the research, we have the tools. Most of them are free in the US through federal programs or covered by insurance. So we really need to engage the lay community. And we are not ready. We started and open to everybody. We have over 40 partners. There's not a written commitment. When a partner want to come on board, we say, what you have to offer. And we publicize that on the website, what each partner is doing. And it has really been phenomenal, because we have partners from all segments of society, from tiny organizations to individuals to large organizations. And once you engage the community, what happened is that they start coming to us to say, I'm a business owner, what can I do? I'm a dentist, what we can do. So what we thought was very important then to really do this education on what they can do. Here's an example, and you have all that on our website. So to me, at least if with the road, I'm a Rotarian, even in my club, that we are the largest club in the Americans, was really amazing when a lawyer understands and get the message. One of our major champions in North Alabama is a pest control guy or a COO of a wood pellet company. And so we thought was very important then to equip these individuals and these leaders to get the word out. So we have materials for them on how to engage partners, how to do an action plan, how to talk about cervical cancer elimination, how to give those talks. But also was very important for most of these champions who are not in healthcare and are out there in those communities is how to talk to people. So we do a lot of motivation interviewing in our champion briefings and train them on how we use what you have here, what has been identified as barriers or challenges, and how they can navigate that in these different scenarios. And has really been well received on how they feel like, okay, now I'm equipped to go back to my town and the fire chief or and really educate the community. Some successes, I don't have time to talk about all of them. I'll focus a little bit on screening since that's the focus today. But I think one of the first things that we learn is that the increased awareness that cervical cancer can be eliminated. I go across the state, and Nancy Wright, who is really a champion from the Alabama Department of Public Health, and other partners, we go across the state, and a lot of educated people, lawyers or teachers, they come to us and say, I did not know that cervical cancer could be eliminated. And so that has really been very important and as a positive message. The engagement of Rotary clubs across the state, because those are the civic leaders that can then mobilize others in those communities as trusted individuals, has really got us going much faster than we anticipated. The faith-based organizations, here's a tool, if you see on your screen, that one of the volunteers developed for a toolkit for faith-based organizations on how they can implement within their congregations, and she's leading that. The engagement of healthcare providers has been critical for us because a lot of them do not know that they get reimbursed at the Medicare rate if they are partnered with the Alabama Breast and Cervical Cancer Early Detection Program for uninsured women. Adherence to guidelines, we didn't talk about that earlier, has been a challenge. And we just did some qualitative work here with providers in the community, and the resistance to transition to primary HPV testing has been really disheartening, and they are not adhering to guidelines. So for the importance for them to adhere to guidelines. And then we also educate those leaders in the lay community to ask their providers what they are doing. And of course, for them to promote the importance for patients to understand what screening is and when they get abnormal, what they need to do. We have increased access to screening and HPV vaccination because what good does it do to increase education and don't increase access? And I think Jennifer talked about that one of the challenges is that a lot of women who get an abnormal cervical cancer screening need to come to the large towns in the state to have follow-up. So the Alabama Department of Public Health trained traveling nurse practitioners. We have 4 located in the corners of the state that they can go and provide colposcopy where women are screened. And they have, just those 4 nurses provide over 1,000 colposcopies last year that's monitored and reviewed by a gynecologist, every single one of them. So that has really been a game changer. We work with students in high schools. They develop a toolkit for other schools. They develop what I have on an activity book to work with middle schools. So that's kind of what we're doing. And we didn't expect that we're just trying to do what was right for Alabama. And then it started a lot of the attention in working with the Association of State and Territorial Health Officers, because I think it's important that they get engaged. For low middle income countries and other countries, through Rotary, we're doing webinars. Rotary International is organizing this, and we have a group that we then are doing those webinars and provide guidance to those countries. And we start working with other states. Louisiana just launched theirs. Oregon is pretty close. And what we do is go and share, really not to do a plan, but how to do it, lessons learned, and has really been very rewarding. I won't have time to go to this slide. I want to just point out 2 things. Don't be afraid to get started. We are not ready. This is, as a researcher, the most liberating thing here is that I didn't need to control all the variables. We start what works, and then we change strategies and really engage everybody. Different partners bring different perspectives and understand the landscape of the healthcare system before they do anything. So we make sure that we follow up on what we commit to. And we talk about statewide plan, and it's important to have that plan, but we have found that it's not sufficient within the champions on the ground. And I can tell you, as a researcher in cervical cancer my entire career, this has been the most rewarding effort to see a whole state come together and really move this forward. Thank you.
Thank you so much, Isabel. A very strong message there, very powerful about working with communities and chipping away at that knowledge base and making sure people are up to speed, whether they're lay or expert. Everyone needs to be updated. Thank you for staying with us. I know we've run over the hour, but I think it was such a valuable presentation from all of our presenters. So it just remains for me to say, look, thank you, everyone, especially Marion, for getting up in the middle of the night for us. I think there's been the power of sharing has come across very strongly, and it's great to see the number of US states now stepping up. And I think you'll all be creating a lot new, exciting data that will also be very valuable for our international colleagues. So thank you, everyone. And please join us for webinar 3. Heather has added the information into the chat, but we'll share a new flyer very shortly. Thank you, everyone from IGCS. Thank you so much. Goodbye.